So after those amazing videos by Dr. Harshal, I'm going to show you less amazing ideas and less amazing tries. Yeah, we're talking about
Intraoperative floppy iris syndrome, and I'm Sajjad.
Fazili from Srinagar. No financial. Oh. Okay. Okay. So we know that beyond preoperative prophylaxis for patients associated with high risk to developing IFIS, um, there are protocols that should ensure that the hazard is highlighted before the surgery, and necessary measures and surgical technique modifications are employed, like Dr. Harshal showed us. Primarily, these patients should also be assigned to the most senior member of the surgical team. But I guess that's also a hurdle to other people learning. The modern way of learning is that you know, get prepared for a certain problem, and then go ahead with that. So we know iris billowing, floppiness, iris prolapse to the incisions, and progressive intraoperative meiosis are the problems here. So you can see as the fluid current goes inside, even before we are doing anything, let's say we are putting phenocaine, or we are putting in trap and blue, or we are washing it off, if the plane of these fluids is above the iris, nothing will happen. But when the fluid current touches the posterior iris, you will see the billowing, iris billowing, and the floppiness. But if it's above it, then you will not see it. But if it is below it, when it's touching the posterior surface of the iris, then there will be billowing, and then there will be thing. Look at this. Surgery, well dilated pupil, you can see with a little bit of hydration, just because the fluid is going underneath also. So we are seeing some amount of billowing. And when the fluid pools behind the iris, surely the iris will billow, and this iris, because it's thinner, it has a propensity to come out from the ports and leading to a floppy iris prolapsing. So the same case, we see we've used topical atropine here. You can see the billowing very clearly. And some people also use epinephrine. We know that epinephrine by now, we know that doesn't help much, but 1% unpreserved lidocaine for IFIS might help a little bit. But as soon as I personally do not use it. I generally speaking use it for all cases as such. We do not dilate preoperatively. The viscoelastic has to have the same principle, that you don't have to go under the iris. Same thing about fluids, and same thing about viscoelastics. And while you're doing the capsulorhexis, you can see in this case the size of the pupil is quite okay. So we are doing a capsulorhexis, and the idea is not to touch this iris. These irises are more sensitive, rather hypersensitive to touch. The moment there is a fluctuation in the anterior chamber, or you touch the iris, it will come down. Here we are seeing, you can see how much this iris is billowing, because like we knew that this is going, hydro procedures are very important, and at the time of hydro procedures, there's a possibility of the iris coming out. You can see at the incision, I'm doing a very gentle hydro procedure, yet the iris has a tendency to come out. So I'm putting viscoelastic in a certain plane and then going ahead. The pupil size has actually come down, but we can see that phaco is still very comfortably possible. And it's also important to keep this floppy iris away from the phaco tip. Sometimes if unintentionally the occlusion breaks, this iris can actually just come in and into and cause a sphincter damage. You can see as soon as I've come out with irrigation, continuous irrigation on, and you could see the iris had come out. And when the pupil size becomes smaller, it's very important for you to have a good vision. And I found this an excellent maneuver to use the Y hook and look and then operate. I would not want you to operate at all. You can see again the iris has a propensity to come out. The viscoelastic, especially a higher density viscoelastic into the anterior chamber at the right plane, usually restores the iris back into the anterior chamber. Then you go ahead and implant a lens, and that should take care of things. Another important step at which you might see uh, the iris coming out is at the time of the stromal hydration. Yeah, if you are putting too much fluid into the anterior chamber, hyperinflating it, the iris will again have a propensity to come out. It will have a tendency to come out. So the hydro procedures, the stromal hydration also has to be very, very gentle and only just adequate. You can see here, what I've done is I've done just a mild, small amount of hydro procedures, and that prevents the iris from coming out when I'm actually cleaning up the viscoelastic. And at the end of removal of this viscoelastic, you can see this is a floppy iris. You can see the billowing now. And as the fluid currents move, you can see. But if you stop the irrigation before you come out, the tendency to have you can see I've stopped irrigation and come out gently, and not to press the lower lip, and then the possibility of iris coming out at this stage might be much lesser, and we complete the stromal hydration. So gentle and minimal hydro procedure, like I told you, is very important. As you go in, the fluid wave comes in and it goes out from the other side. If it comes out, if you pushing too much fluid inside, what happens is that the fluid comes out and touches the posterior surface of the iris, and that's where the floppiness starts. And you can see right at the hydro procedures that there is iris prolapsing. You can see here I'm trying to do a hydro procedure. The rhexis is already done, and you can see the iris is trying to come out. Like Dr. Harshul demonstrated very nicely, it's better to deflate the anterior chamber a little bit. I'm doing that now. I was not doing it earlier. And now I have a plane and I'm putting in viscoelastic, and the iris is pushed back. It's always good to use higher density viscoelastic whenever you want to. But you can see this is another case where the pupil size is not that great. But I think I can go ahead and operate this. You can see even the air bubble is running through and going back. Use of intracameral epinephrine or other things, I don't think that increases the size much. You can see I have been able to complete this case, turn off the irrigation to reduce the intraocular pressure before removing the phaco tip. And same goes for the IA. When you come out, you stop the irrigation and then you come out. That doesn't mean that it might not happen. It can still happen, but the possibility is less. You can see this is an anterior placed incision. Anterior placed incision, this is 2.2. So I've actually gone ahead. The idea here is that you might have a little difficulty. There may be a little overlocking here and there. But an incision like this you are actually in an area where the iris will have less tendency to, so that's very important regarding the incision. And you can see the side ports also are slightly longish, and if possible a little anterior. Again, when we start off doing phacoemulsification, that time these type of incisions might be a little difficult, but with a little bit of experience, we usually get over with that difficulty. Because the problem with longer side ports and longer incisions, you can see the billowing is here. The iris is moving as the fluid currents are passing. You can so surely I know this is. So this is where I should have gone ahead and implanted a pupil expanding device. But I continue to do what I'm doing, and I think my pupillary size is good enough. That sign was so critical. That amount of billowing was so important. I should have intervened at that time. But we can see now that everything seems to be going on fine. You can see I have now removed the viscoelastic and deflated a little bit, done a hydro procedure, not much. Now we can see, yeah, there's a tendency for the iris to come out. And this is almost a severe IFIS. Severe IFIS. So now I'm still going on. Right now I should have played it safe, but I'm not playing it safe, and look what happened. Look what happened. We can watch this again a little bit. See, I'm here, I'm trying to chop, I'm going near the pupillary margin, that's what happens. That's what happens. That's what I did not decide right at the center, that I should be using a pupil expanding device and make it a safer thing. Now that the damage is done, and I still need to change my strategy, because recognition of a problem and admitting a mistake and moving on and making corrective measures. So iris retractors are being put. Now what these iris retractors do, they provide sufficient tension to the iris stroma. Iris retractors should ideally have been put right at the start when I was doing, because the rhexis is made here. I have to be careful that it does not come into the capsulorhexis margin. Once the hooks are there and the pupil is stable, they have sufficient tension to the iris stroma. Now I can go ahead and finish the case in a comfortable way. You see, this is another thing we have to look at. The pupil is big, no main port, but from the side port, so the iris is coming again and again. And I am trying to visco-reposit it again. That's not the best way always, because that much of prolapse needs going through another port and putting it inside. So revisiting the port construction, perhaps like I told you before, we should be making these ports slightly different. And the incisions, when IFIS is expected, slightly longish, side port incisions also, apart from using pupil expanding devices. Yeah, these are good steps, and they help in avoiding the IFIS. Now this is again another case of severe IFIS. You can see I've fashioned the incisions quite anteriorly. So things look quite all right. The pupil size looks very manageable. So I go in and viscodilate, and I can see nothing is happening right now, and things seem to be moving quite okay. There was not much billowing also. But as soon as I complete the rhexis, I can see my pupil size is going down. Now, till there, everything is fine. I told you the important step is the hydro. As soon as I'm doing hydro, you can see now the iris is coming out. Also, the pupillary size is going down. I'm dialing the nucleus, and you can see now this pupil size is not good. Again, because I think I might be able to manage this. Again, a mistake. This is surgery done quite a long time back. That time we did not understand this that well, but you can see the iris is quite floppy now. Now we don't have a choice. I told you that surgery means constant planning and dynamic decision making. So one option would be that you always, whenever you see billowing, whenever you have a patient who has a history of tamsulosin intake, you go ahead and put the rings right at the start and make the surgery safe. But if you've not been able to do that, there's always time, and there's always the right time to put in new steps so that you are able to handle it. I'll skip this surgery. This is another case of severe IFIS. Now, there might be certain problems that might occur with the struggles at the main port. You can see the iris has come out here. So I'm trying to reposit it. I've gone through the side port, and I'm trying to bring this iris back. This would, iris has memory. So this, generally speaking, this would be the best way of doing it. But we also showed you in earlier surgeries that viscoelastic is quite good enough if your chamber is not deep. See, I'm trying to go in. The iris is trying to come out. I'm going in, and you can see the iris coming in front of me also. But I realized that this repeated effort to go in and come out has caused a descemet detachment. So this is one of the problems which can be associated with troublesome incisions from where the iris is coming out. So I leave this incision as it, leave the Descemet's detachment you can see, and make another incision and complete the surgery from another incision. And the pupil will always be unreliable, we know that. So I will skip this surgery. Important thing which Dr. Harshal pointed out is the better option would be to use the bimanual. But with small pupils which we encounter with IFIS, I think more surgical skill is needed, and let the best man operate. And iris retractors, although time consuming, may consume a little time, are sometimes preferred by cataract surgeons over pupil expanders due to their significantly lower cost and better safety profile in cases with the shallow anterior chamber. When applied, one of the retractors should be located directly beneath the main incision, forming a diamond shaped pupil, thus pulling the iris away from the phaco-tip and decreasing the risk of the iatrogenic trauma. In this case, you can see a clear corneal incision behind which we are placing another port from where the iris hooks will be placed. I'll just move this. You can see good amount of exposure. The iris is very comfortably and in control. And on other hand, pupil expansion devices are most common cases, much easier to use, require less operating time, as Dr. Soin will show us, do not require extra incisions, and provide a stable pupil during the surgery, minimizing the post-operative pupil deformity and the anterior chamber inflammation. So in the end, we're talking about a careful incision location and construction, use of less aggressive, low flow, phacoemulsification, fluidic parameters. They are able to effectively control iris behavior and lead to much lesser cases of IFIS. A gentle hydrodissection is very important. Minimum in and out movement, and keeping the iris flow above the iris plane should be helpful. I thank you all for your kind attention. Dr. Swin, come on, tell us how your pearls.